The following episode is brought to you by the American Urological Association. This episode comes to you from the AUA 2024 instructional course, How to Use PSMA PET CT in the Management of Relapsing Prostate Cancer Patients Following Local Therapy with Curative Intent. For more information on how to claim CME credit or to view faculty disclosures, please visit the AUA University at auanet.org/university. Support for this episode has been provided by Astellas, Janssen Biotech Inc., administered by Janssen Scientific Affairs, LLC, Lantheus Medical Imaging, Merck & Co., Inc., Novartis Pharmaceuticals Corporation, and Pfizer, Inc.
And I would like to welcome you for this instructional course on PSMA PET CT scan in patients with prostate cancer, primary diagnosis, and also biochemical relapse. I have the two faculty members with me, Deborah Kane from Duke University and Jeff Carnes from the Mayo Clinic. And we have distributed the contents of the presentations among us. So I will give you a short introduction on the mode of action of PSMA, how it works, how different tracers, which kind of different tracers you have, and how you would use them in clinical daily routine. And then Dr. Kane is giving you some ideas about primary staging and high-risk localized prostate cancer or locally advanced disease. And then Jeff Carnes will give you some information about biochemical relapse. And then I will conclude the session with radiorecurrent disease. And now we will start the presentations. And it is my pleasure to start at first to give you some introductory slides and also to discuss two cases together with you. This is the description of our course. So what we would like to transfer with regard to knowledge is how to use the PSMA PET scan in the clinical scenario. I will give you some ideas about the mode of action, the pitfalls of a PSMA PET CT scan, so false negative and false positive results. We will give you some information about the diagnostic accuracy of a PSMA PET CT scan, depending on the PSA doubling time, and prostate cancer histology on biopsies or radical prostatectomy specimens. We will give you some information how to apply PET CT scan to identify patients who might have an intrapelvic nodal relapse and who might benefit from local treatment, be it either salvage lymphadenectomy, salvage radiation therapy. We also will give you some information about the application of PSMA PET CT scan in radiorecurrent prostate cancer to stratify the treatment options, local salvage treatment, systemic treatment, maybe radiation therapy. And last but not least, we will give you some information of the application of new PSMA PET-based clinical staging systems, the PROMISE network, which is a very easy standardized interpretation of a PSMA PET scan. It's very objective, and it takes away the subjective interpretation of there is some, let's say, PSMA-V lesion with low or high SUV values. Those is the faculty. As I said, Deborah Kay is Assistant Professor of Urology at Duke University. Jeff Carnes is a professor of urology at the Mayo Clinic in Rochester, and he has done a lot of work about prostate cancer, also in the situation of salvage treatments. And myself, I'm a professor of urology at the Department of Urology in Cologne in Germany. I did have the EUA prostate cancer guidelines for about 8 years, and my special interest is prostate cancer, and on the other hand, it's testicular cancer. This will be the agenda, so I will give you a little bit information about the background. Dr. Kay will give you the information how to use a PSMA PET CT scan as the initial staging tool in newly diagnosed high-risk prostate cancer. Then we go for biochemical relapse following irradiation treatment. We go also for PSMA PET scan in the situation of biochemical relapses. And depending on the time and your questions, we also can go through different cases, which we might discuss in an interactive mode. So let me give you some information. This is the agenda of my talk. Why do we use PSMA as a new innovative imaging study? This is based on these immunohistochemical expression of PSMA in prostate cancer cells. What you can see is two things. We have different types of staining patterns with PSMA. On one hand, we have cytoplasmic staining, and on the other hand, we have membranous staining. And also, only the membranous staining is the staining which makes a lesion PSMA-vid, because all these PSMA receptors are on the surface of the cell and not located intracellular. We have some information. PSMA PET scan, at least here in the United States, was approved in 2020. In Germany, in my institution, we use PSMA PET scans since 2011, and we have done probably more than 3,000 or 4,000 of those PSMA PET scans in different clinical scenarios. What has already been shown many years ago is that the PSMA expression on prostate cancer cells is associated with high risk of relapse, independent if you use PSMA staining on a biopsy or if you use PSMA staining on a radical prostatectomy specimen. And as you can see from this small table, the more PSMA expression you can see in prostate cancer cells, the higher is the risk of a 5-year relapse. The PSMA expression just on a prostate biopsy sample, if it's, for example, high, is associated with a 4-fold increase of disease recurrence, independent on the type of local treatment you might deliver to your patient. And what you need to know is that the PSMA expression increases with the progression of the disease. So it's usually higher in patients who have either metastatic hormone-sensitive disease or castration-resistant disease. And this is the reason why we use the PSMA lutetium therapy, Pluvicto therapy, in most patients who now develop metastatic castration-resistant disease following combined androgen deprivation therapy plus minus cytotoxic chemotherapy. So those are the different clinical scenarios when you might use a PSMA PET CT scan. So it has been shown that it is a very valid tool to identify occult metastatic disease in patients who have locally advanced high-risk prostate cancer. It is a very valid tool to identify the localization and the extent of metastatic disease or locally recurrent disease in patients who have been treated either by radical prostatectomy or by radiation therapy. It is a good staging tool in patients who have metastatic MSHPC, and as I said, it's a good staging and treatment decision tool in patients with castration-resistant disease. How does a PSMA PET CT scan work? So PSMA itself is a transmembrane protein which has a 100 to 1,000 fold expression in prostate cancer cells. The ligand binds to the PSMA receptors. The PSMA receptors are intracellularly internalized after binding via a specific coded PIT and endosome accumulation. And thereby you have this enhanced intracellular accumulation, which you can use for diagnostic and also for therapeutic purposes. When you have a patient who might be scheduled for a PSMA PET CT scan, there are only very few things you should remember, or at least you should advise your patient to. At least he needs a good hydration, because the gallium PSMA is excreted by the kidneys. He does not need to be fasting, but at least a good hydration is necessary to give good PSMA PET CT scan results. As you can see, there is a renal excretion of gallium PSMA, of the gallium PSMA, and this has some advantages but also some disadvantages. It might result in false negative results if you have small locally recurrent deposits, which are then hidden by the bladder, for example, if it's filled with urine and you have all this gallium PSMA in the bladder. There should be a 60-minute interval between the injection and the imaging. And then at first, nuclear medicine people usually get a plain CT scan from the skull to the lower extremities. And thereafter, you have your PET images, and then you do the fusion of the images. What you always have to be considered is that PSMA is not prostate cancer specific. So there is always the danger or the possibility that you have false positive results. You have to remember that there is a physiological expression of PSMA in the kidney, in the salivary glands, and also in the small intestine, the liver, and the spleen. So whenever you see PSMA-avid lesions in those areas, you always have to think about the possibility of false positive results before you start any type of treatment. The expression of PSMA is also associated with inflammatory associated angiogenesis. So we have many reports that a PSMA PET CT scan will be positive in renal cell carcinoma, and actually it is used for staging tools also in renal cell carcinoma. It can be positive in gastric, colorectal, breast, and thyroid cancer, and it also can be positive, and I will show you some examples later on, in benign inflammatory disease, for example in sarcoidosis, in lupus erythematosus. So that's one thing you have to remember. It's not prostate cancer specific, and I will come to this in a minute. There is a normal physiological distribution of the gallium PSMA PET tracer, and you can see it on this image. You have a moderate activity in the salivary glands. You have a moderate activity in the liver and the spleen and the proximal small bowel. And whenever you use gallium PSMA, you will have moderate activity in the bladder. You have always a strong activity in the kidney, and these differences in activity, spleen and liver, kidney and bloodstream, will then be analyzed in the PROMISE score, which I will show you at the end of the presentation. Those might be the pitfalls of PSMA PET CT scans. So you have the celiac ganglia and the ganglia of the sympathetic chain, and those are always positive in every single man, in every single female. So whenever you see this type of PSMA-avid lesions, which are located in the retroperitoneum and which are located just around the aorta, for example, then you should have the suspicion that this is a false positive result. It does not resemble small metastatic prostate cancer involved lymph nodes, but it's just a physiological distribution. What you also can see, and due to my age, I have to get my glasses. What you also can see is when you look at the SUV values, which are shown down here, they usually do not exceed 3.0. You also can see that there is a different expression mode, but most of these patients with the celiac ganglia have some type of moderate PSMA expression. Beside gallium, we have another, the fluoride tracer, which can be used. The fluoride tracer has some advantages and some disadvantages. The advantage is that the fluoride tracer is not excreted by the kidney, so you will not have false positive or false negative results due to some activity in the ureter or due to some activity in the bladder. The drawback is with the F18 PSMA, you might have false positive results in the bone. For example, if you have a healing fracture in the rib. So whenever you see a patient who have PSMA positive lesions in the ribs, as you know from skeletal scintigraphy, it could be everything from metastatic disease, a trauma, a healing fracture, arthritis, whatever. Also, F18 might be positive if you have osteophilic lips just close to the small joints, either in the small pelvis or the vertebra. And then every single patient who might have osteoarthritis will be positive with F18. Fortunately, there is a different tracer. It's also F18, but the 1007 tracer. It has a longer half-life. It has a lower positron energy. It also has a non-urinary excretion, and it is more specific for bone. You will not have false positive results if you use F18 1007, which was developed in the Department of the Nuclear Medicine of my institution. So this is an example. You have your plain CT scan of the small pelvis, which apparently looks quite normal. If you use the F18 tracer, you will see this very small PSA, or not very small, but you can see the PSMA-avid lesion. Going back to the native CT, there might be a zone of sclerosis, which could be also everything, metastatic disease from benign disease, but this F18 1007 tracer will give you the identification of a metastatic lesion. We have done such a study in close to 700 patients who have received a PSMA PET scan with the typical tracer, so it could be everything, could be a gallium tracer, it could be F18 in different scenarios. And we identified 27 patients who had a completely negative PET CT scan by using one of the traditional markers, or patients who had equivocal PSMA positive spots close to the area which could resemble both just benign disease, metastatic disease, false positive, false negative disease. And we repeated the PSMA PET scan with this F18-1007 tracer. And what we identified, and then we had a classification for our interpretation, similar to the PIRATE system you use in a multiparametric MRI. So if we have PSMA REDS 1 or 2, we know it's a benign lesion. The 3 is always an equivocal lesion, and 4 and 5 is typically malignant. When we analyze those patients, these are some of these examples where you can see that this F18-1007 tracer will identify many of these very small spots which will not be identified by a gallium PSMA PET CT scan. So our policy right now is we start usually with a gallium PSMA PET scan if we want to look for systemic metastases or if we monitor patients under active treatment. If, however, we have the idea or the suspicion that patients might have a local relapse after radical prostatectomy or after radiation therapy, we use the F18-1007 tracer to be sure that we can identify the most likely spot. This is a different study comparing gallium PSMA and F18 PSMA, not the 1007 tracer, but just the typical F18. And as you can see, the conclusion is that by using this tracer, you have many equivocal findings, especially in the skeletal system. So whenever you want to evaluate a patient with regard to the presence or absence of skeletal metastases, you should use the F18-1007 tracer. Last but not least, I will allude to this prostate cancer molecular imaging standardized evaluation protocol, which is very important in clinical daily routine. I don't know how it is in your place when you send a patient for a PSMA PET CT scan and you receive the report, and sometimes it's a little bit vague. There is a little bit of SUV increase at a specific space. We don't know if this is metastatic disease. It could be metastatic disease. There's a highly likelihood. So nothing you can work with to counsel your individual patient. But if you use this type of promise criteria, you can see that there is that they use a different reporting tool. So you have 3 scores: no, low, intermediate, and high. And these different scores report to the PSMA expression at different anatomic localizations. So usually if your SUV is below the SUV of the PSMA expression in the bloodstream, you know this is not due to metastatic disease. When it is equal or above the pool or lower and lower than the liver expression, you know this is not metastatic disease. And using this different scores, you can have a look at the different PSMA PET scans. So this is the expression in the salivary glands. We have the expression in the liver, and then we have also the expression in the blood. And based on these expression profiles, we can use type of an molecular imaging TNM system. So whenever we receive a report of our PSMA PET scan nowadays, we will get the information about the local extent of prostate cancer. We will get the information of lymphonodular involvement, and we will get the information of distant metastases, presence or absence of distant metastases. And you can also go a little bit more in detail. You have a segmentation of the prostate gland, so your nuclear medicine people can give you the exact determination where in the prostate is this PSMA positive focus located, and you can make your decision how to treat it: radical prostatectomy, radiation, focal therapy, whatever. We also have the different patterns of bone involvement, just a solitary metastasis, oligometastatic disease, or advanced disseminated metastatic disease. And also with regard to the lymph nodes, there's a specific classification system giving you the idea where exactly those lymph nodes might be located anatomically, and this will help in the treatment decision process. Salvage radiation treatment, stereotactic radiation treatment, salvage lymphadenectomy, because like a year ago we received the report telling us there is a lymph node around the iliac vessels. So it could be everywhere, from the common iliac to the internal iliac, the external iliac. With this type of classification system, you have the exact knowledge where these metastases might be located. And those are some examples. So in primary staging, you will receive the information it's a T3A tumor. There is one positive lymph nodes in the obturator fossa on the left side, but there is no evidence of systemic metastases. On the other hand, in patients who have biochemical relapse, this type of PROMIS classification gives you the idea there is no local relapse, there is no lymph node metastases. However, there is a positive metastatic spot in the retroperitoneal lymph nodes. So in summary, the gallium PSMA PET CT scan is the most commonly used tracer. I'll have to get the mouse somehow in there. It's the most commonly used tracer for the evaluation. The PSMA expression increases with biological aggressiveness of prostate cancer. And you have to remember, PSMA is not prostate cancer specific. It can be positive in benign and in malignant disease. So whenever you identify a potentially positive PSMA lesion in a very, very unusual anatomic place, the spleen, for example, let's say the liver in the primary staging, we usually biopsy this lesion to be sure that this is metastatic disease and not benign disease. As I said, there are some pitfalls of the PSMA PET CT scan due to renal excretion if you use the gallium PSMA tracer, resulting in false negative and maybe also in false positive results. I guess we can just discuss two cases before I transfer the presentations to Deborah Kay. This is a young patient who had been diagnosed with locally advanced prostate cancer. It was a clinically T3B cancer, also on the multiparametric MRI. We had involvement of the seminal vesicles. There was no evidence of lymph node or systemic metastases. He had an ISOP 5 in 19 out of 19 biopsies, and his initial PSA was 125. So the policy in our department is to start patients on combined neoadjuvant androgen deprivation therapy. Usually it's ADT plus apalutamide, and based on the idea of the Proteus study. With Proteus study, we just are in the time point of doing the interim analysis. So most probably at ESMO this year, we will have the first results of the Proteus study. So the patient responded quite well to this combination therapy. His PSA dropped to 1.0.4, which is not a very good prognostic sign, but at least it's a good decline. In multiparametric MRI in the PSMA PET scan, there was a regression, but still significant AVID activity. And when we looked at the PSMA PET scan, there was a nodule just close to the wall of the rectum. And you can see this nodule also here, which is not infiltrating the rectum, but there is a very, very, very close vicinity to the serosa of the rectum. So the question now is, what kind of approach would you use in this situation? Would you go for radical prostatectomy, pelvic lymphadenectomy, and resection of this atypically located node? Would you start on radiation therapy, so IMRT and IGRT, or would you just continue the hormonal therapy as the only treatment option? You have a couple of seconds if you want to answer the question, and then I can tell you what we did and how the PSMA PET CT scan fits in this situation. And again, whenever you have questions or whenever you have some points of criticism, please be so kind and ask us, and just use the microphone to ask your question, because everything is recorded. So the majority would go for radiation therapy. Okay, and then a minority would go for radical prostatectomy. Now, maybe I can ask the ones who have chosen radiation treatment, would you only radiate the prostate and the pelvic lymph nodes? Or would you also somehow include this PSMA avid lesion close to the rectum by stereotactic radiation therapy or whatever? What would be your approach? I mean, prostate and seminal vesicle and the whole pelvis is clear based on the prospective randomized trials. You should always include the pelvic lymph nodes, but we still have this small nodule which could be treated by continuing the ADT for maybe a year or 2 years, but which probably cannot be treated by radiation therapy because you have a very high risk of a fistula. So what we did is we went for radical prostatectomy. Turned out to be PT3B disease. There is no evidence of lymph node involvement. There was a small positive margin of 2 millimeters and a Gleason pattern of 4. And a small nodule resected was not metastatic disease. It was a schwannoma. And false positive results in these benign diseases, I just allude to it on this slide. There are schwannomas, so just benign tumors of the nerves, which might be PSMA positive. So again, whenever you have this type of PSMA avid lesions in very unusual localizations, just think about the potential of a false positive result. Second case I would like to discuss with you is a patient who underwent radical prostatectomy for biopsy-proven prostate cancer. It was a PT3B disease. He had 2 out of 27 lymph nodes positive, but no extracapsular invasion. There was an ISO5 tumor, and surgical margins were negative. The patient received adjuvant ADT for 2 years, which at that time, 2012, was our standard approach. And then after a couple of years, he had a PSA rise to 2.5 nanograms, a moderate PSA doubling time of 12.1 months, and then he underwent a PSMA PET scan. And the PSMA PET scan identified this single splenic lesion, but no other evidence of lymph node involvement, no evidence of skeletal metastases, and no locoregional relapse. Again, the question is, what would you recommend in this situation? Would you treat the patient in terms of intensification of systemic treatment, either adding a novel hormonal agent or docetaxel? Remember, it was in 2012. None of these combination therapies were approved at that time. Would you counsel him just to do a splenectomy, or would you take a biopsy in this situation? Yeah, perfect. So everybody did listen to my previous elucidations to the slides. So the biopsy is the best way to do. And this is what we did, and the biopsy demonstrated sarcoidosis. So again, highlighting the fact whenever you have a PSMA avid lesion in some unusual anatomic areas, please just get a biopsy prior to the treatment. That would be all from my side. I guess I can close my presentation. And I'm happy to take any questions if you have them just to this type of mode of action or indication of PSMA PET scans. Please.
Thank you. For that last case, so PSA doubling time's about a year. When would you get your next scan typically? Would you wait till the PSA doubles again? Do you get it every year?
On this situation, so the PSMA PET scan was negative, doubling time was moderate. So I usually get the next PSMA PET scan if the PSA rises above 2, because then we know these primarily negative patients usually will switch to positive patients. If, however, there is still with the PSA of 2 a negative PSMA PET scan, I would go back to the histology. We have a couple of patients who demonstrated some intraductal prostate cancer elements in the radical prostatectomy specimen, or we had some cribriform elements or small neuroendocrine elements, which were then responsible for the PSA rise, but which are not detectable by a PSMA PET scan because all these elements are PSMA negative. In this situation, I get an FDG PET CT scan, which is usually positive. And then with regard to the intensification of systemic treatment, I would start intensification if there's a switch from the PSA doubling into less than 1 year. In this specific scenario of the patient who only had ADT, if, for example, he would have been diagnosed with a doubling time of 6 to 9 months, I certainly would have added a novel hormonal agent, and at that time, I would have started molecular analysis to identify some type of HRD mutations. Okay, then I guess we can continue with your presentation.
Great, good morning. Thank you for joining us today. So I'm going to be discussing PSMA PET as an initial staging tool in newly diagnosed prostate cancer, and just going over all the different bodies, the guideline panels. My disclosures is I'm a consultant for Janssen. And so as we just heard, imaging for prostate cancer is challenging. Conventional imaging is mainly based on size, where early metastatic disease is small, and large nodes can be benign, and evaluation of osseous metastases are difficult. Routine FDG PET is not sensitive for prostate cancer, and there are real clinical needs in accurate initial staging, as well as evaluation of biochemical recurrence, and then development of imaging biomarkers specific for prostate cancer. So I'll skip this. We already heard why PSMA, and what is PSMA. And then the important thing is this idea of standardization, and I don't think that we've done a good job yet of doing this, but various groups have proposed different standardization methods. A big one is the PSMA RAD score, which we discussed a little bit earlier. So just to go over the guidelines, both for localized as well as biochemical recurrence. The different bodies have different guidelines. So to begin with, the NCCN guidelines, which were updated in 2024 for localized disease, recommend PSMA PET to consider it in unfavorable intermediate risk disease. And for high risk disease, you can also consider PSMA PET. But for biochemical persistence, relapse, progression, they do recommend a PSMA PET. There are various PSMA agents that are endorsed by the NCCN guidelines. And once again, as we just discussed, the PSMA PET or PET MRI can be an alternative to standard imaging of both bone and soft tissue. And because of the increased sensitivity and specificity of PSMA PET tracers for detecting micrometastatic disease compared to conventional imaging, at both initial staging and biochemical recurrence, the panel does not feel that conventional imaging is a necessary prerequisite for PSMA PET, and it can be equally as effective. So you do not need conventional imaging prior to PSMA. However, as we've previously discussed, there is a real potential for false positives. And so the guidelines do recommend either histologic or radiographic confirmation of a positive finding whenever it's possible, and also based on risk categories. And then PSMA imaging should not be completed before initiation of ADT, because ADT may affect detection sensitivity. So it's just also important to keep that in mind. So to transition to the EAU guidelines, also from 2024, for intermediate risk disease, they recommend cross-sectional abdominal pelvic imaging or a bone scan, but a PSMA PET if it's available to increase accuracy. For high-risk disease, once again, a PSMA PET CT if it's available, and then at the very least, cross-sectional abdominal pelvic imaging and bone scan. For biochemical recurrence after radical prostatectomy, the EAU guidelines recommend a PSMA PET if the PSA is greater than 0.2 and if the results will influence treatment decisions. And that's key throughout the EAU guidelines. And we'll go into the risk stratification system briefly afterward. However, if a PSMA PET is not available and the PSA is greater than equal to 1, You can perform a flucyclovine or a choline PET CT, once again, if it will influence treatment decision making. And then after radiotherapy for biochemical progression, first you can get an MRI to localize and guide biopsy, and once again a PSMA PET if it's available, or a flucyclovine or choline PET in patients fit for curative treatment. So once again, if it's going to help guide decision making. The EAU guidelines strongly recommend using the biochemical risk stratification system. So just in terms of understanding what your PSMA means and in ordering it as well. So keep in mind their actual likelihood of having true biochemical recurrent disease. And important to keep in mind that they stress throughout that treatment should not be changed based on PSMA PET findings alone. And then another thing to keep in mind, as we've already discussed, is that the biochemical recurrence, PSMA positivity, increases with increasing PSA. So from, this is a meta-analysis, and less than 0.2 is about 33% PET positivity, and when you're greater than 2, it's about 95% PET positivity. So we'll transition to the AUA guidelines, which were just released a few weeks ago. So for localized prostate cancer, clinicians should not routinely use CT or bone scan in asymptomatic patients with low or intermediate risk prostate cancer. They should obtain a bone scan and either pelvic MRI or CT scan for patients with high risk prostate cancer. And in patients with prostate cancer at high risk for metastatic disease with negative conventional imaging, clinicians may obtain molecular imaging to evaluate for metastases. These are actually the guidelines that were just updated 3 weeks ago, the biochemical recurrent guidelines. In patients with biochemical recurrence, clinicians may obtain a PSMA PET in lieu of conventional imaging or after negative conventional imaging for further evaluation of clinical recurrence. And they actually make a very strong statement next for patients with biochemical recurrence following radical prostatectomy in whom salvage radiation is being considered, the clinician should perform next generation molecular PET imaging. And that's a strong statement because, as you know, a lot of these guidelines are often a little bit wishy-washy, but this is a strong should perform next generation molecular PET imaging. And then just to finish up for the biochemical recurrence for AUA guidelines, in patients with biochemical recurrence, clinicians may obtain a pelvic MRI in addition to PET CT for evaluation of local recurrence. And that's important once again because these PSMA PETs aren't going to pick up everything. And in a patient with biochemical recurrent following radical prostatectomy, clinicians should not withhold salvage prostate radiation therapy in the setting of a negative PET CT. So there are various other bodies, the ASCO imaging guidelines, basically for very high and very high risk of presentation. If conventional imaging is negative, you can consider a PSMA PET. If it's positive, you don't need one. For rising PSA after radiation, if it's negative and local therapy is inappropriate, once again, you don't get a PSMA PET. If they're suitable for local therapy, then you do consider it. With the rising PSA after surgery, if, once again, you only consider it if they're suitable for local therapy, metastatic prostate cancer diagnosis, or after initial treatment for hormone-sensitive disease, they say you can potentially get a PSMA PET. And that's really to clarify disease burden, and once again, if it's going to change your management. For non-metastatic castrate-resistant prostate cancer, there's really limited data, and so you can once again consider it if a change of clinical care is being considered. And then for metastatic castrate-resistant prostate cancer, if there's no progression, it's unclear the role. If there's progression, there's no real role for PSMA PET. And then the last one, there are a lot of them, the Society of Nuclear Medicine Appropriate Use Guidelines. These are a little bit older, from 2020, but basically they say it's appropriate for newly diagnosed unfavorable, intermediate, high risk, or very high risk prostate cancer. And you can either do it with or without conventional imaging. It's appropriate for PSMA persistence or PSA rise from undetectable level after radical prostatectomy. if there's a PSA rise above the nadir after definitive radiotherapy, and in non-metastatic castrate-resistant prostate cancer on conventional imaging. So as you can see, there are strong similarities across, but there are some minor differences across the bodies. So now we're just going to go into PSMA PET for initial staging and just look at some of the initial studies. And so this is the pro-PSMA trial. There were 302 patients with unfavorable risk prostate cancer who were considering curative treatment. And they were randomized from 2017 to 2018 to undergo initial staging with conventional imaging versus PSMA PET. And then following initial imaging, all patients crossed over to be staged with PSMA PET or with conventional imaging. And I'm not going to go into too much detail, but basically they found moderate sensitivity, but higher than conventional imaging. So you can see sensitivity on the bar furthest to the right. The red box is the PSMA PET. The blue is conventional imaging. And you can see the sensitivity for PSMA PET is much better across any metastatic disease, pelvic nodal disease, and distant metastatic disease than conventional imaging. Not as much so, a little bit more so in specificity, but there's high specificity throughout. And in this study, they also determined that PSMA PET changed management. And so accordingly, in 28% of patients who underwent PSMA PET as first-line imaging, they underwent a change in management compared to 15% of patients who underwent standard imaging or the conventional imaging group. The next study, the pivotal study used for the FDA approval of gallium PSMA for the primary staging indication, was a single-arm phase 3 prospective trial of diagnostic efficacy. It was performed at UCSF and UCLA. And basically, we'll focus, the whole study recruited over 700 patients from 2018 to 2021 with intermediate high-risk prostate cancer for initial staging. We're going to focus on the subset of 277 men in the study who underwent surgery. And the primary outcome of this was the detection of pelvic nodal disease, which was noted in about 40 patients based on PSMA PET, or 14%. And so, unlike the pro-PMSA trial, all patients in this study underwent radical prostatectomy with PATH as the gold standard. And so this found, similar to the prior study, a high specificity of 95% with not as great sensitivity of 40%. So the authors concluded that there's high specificity, but they may miss small pelvic nodal metastases, and therefore in clinical practice, a negative PSMA PET does not mean that you cannot do a pelvic node dissection. The next trial is the OSPREY trial, which is a prospective multi-center study which was designed to evaluate the safety and diagnostic performance of 18F PET imaging in detecting pelvic lymph node metastases and distant metastatic disease in men with prostate cancer. There were 385 patients eligible overall. Cohort A was the localized cohort, so that's the one we'll review for this. And basically they had 268, I can't quite see it, studies and patients in that cohort. They, once again, the common theme throughout all of these, high specificity and fair sensitivity. So for all pelvic lymph nodes, it was about 98% specificity and 40% sensitivity. It was a higher sensitivity of 60% for larger pelvic lymph nodes, those greater than 5 millimeters. And then Dr. Heinrich's study of 68 gallium PSMA PET, and the role of this study was to assess the role of gallium PSMA PET to detect pelvic node metastases in newly diagnosed treatment-naive high-risk prostate cancer patients prior to radical prostatectomy and extended lymphadenectomy. And so this was a retrospective single-center study from 2017 to 2021 that included 165 high-risk prostate cancer patients, and only patients who received multiparametric multiparametric MRI imaging and MR fusion biopsies at the Department of Urology were included. There were no outside referrals. Each patient went a PSMA PET 1 week prior to radical prostatectomy and an extended pelvic lymphadenectomy. Mean age of patients was 66.7. The mean PSA was 24.5. And number of dissected lymph nodes per patient was 21.5, so a very high lymph node count. Once again, the recurring theme, high specificity and okay sensitivity. So specificity was about 94.5% and sensitivity was 40.4%. So the conclusions or takeaway from this study was that gallium PSMA PET is superior to conventional imaging. With positive activity, about 90% will have metastatic disease, and so you always, in those cases, perform an extended lymph node dissection. However, with negative activity in 21%, there are false negatives, and so once again, you can exclude a lymph node dissection in these patients, but we also need innovative imaging studies to be evaluated in order to spare the lymph node dissection. And from this study, the authors make the conclusion that conventional imaging should be replaced by PSMA PET CT. There's superior detection rate of metastatic lymph nodes, and maybe in Europe, not in the US yet, but lower costs, still quite high in the US, potentially depending on insurance approval, but lower radiation exposure as well. And the last study I was going to go through is a study by Mon colleagues where they used prospective trial data from 2 trials to help identify the best candidates for PSMA PET imaging as the primary staging approach among men with high-risk prostate cancer and negative conventional imaging. So basically, they were trying to evaluate predictors of overall upstaging by PSMA PET from conventional imaging. And they found that the 2 most important characteristics were pathologic grade and disease burden in the prostate biopsy. And those were the 2 most important factors for upstaging. And from that, they developed this tool to predict the probability of upstaging. And it just gives a nice summary of when potentially you should use PSMA PET if you're not sure. So once again, in summary, PSMA imaging overall is superior to Axumin or conventional PET. PSMA PET CT has many applications in initial staging of intermediate and high-risk patients, cancer recurrence, as well as treatment decision-making. But it's really important that you have correlative CT or biopsy findings when you have a PSMA PET positive finding, especially if it's an unusual location. Thank you.
Yeah, are there other questions from your side with regard to the use of the PSMA PET scan, or maybe also to make changes of treatment based on the PSMA PET scan? Please.
Thank you. One question on the guidelines. It stated that they recommend confirmatory imaging for positive PSMA PET. Does that include just the localizing CT that you usually get with it, or is that suggesting we should be getting something more detailed to confirm the avid areas?
Yeah, thank you for that question. You don't always need imaging, right? So if it's an unusual situation, if the history isn't quite what you would expect, if the location isn't quite what you would expect, then you may want to go for additional imaging. So you don't always need pathologic or imaging to follow it up. It's more if it's unusual. There are certain circumstances for bony lesions. Depending on, as we spoke about, you may want to get additional imaging, whether it's an MRI, a really bone-dedicated CT, to look at some bone findings, depending on what tracer you use.
Thank
I
you.
would like to ask the question to you and also to Jeff. So we have the PROMISE study. So let's say you have a patient who has been diagnosed with high-risk disease, so it's an ESOP5. You have clinical suspicion of seminal vesicle invasion. You do your PSMA PET scan, and then the PSMA PET scan demonstrates one positive single solitary retroperitoneal lymph node of maybe 1.5 centimeters. In the PROMISE trial, they switch treatment from radical prostatectomy or radiation therapy to palliative treatment. And this is always my question, is this justified? Because all of our data on locally advanced high-risk prostate cancer patients treated with prostatectomy or with radiation plus ADT have this 15-year overall survival of about 90 to 95% without any PSMA PET scan, and knowing that a number of patients would have had this solitary lymph nodes also. So what is your approach if you would be faced with a solitary lesion? Still go on with your, let's say, local treatment in combination with ADT if you prefer radiation, or switching treatment?
Yeah, that's a good one because I feel like it comes up a lot. So I actually start this conversation with my patients prior to ordering PSMA PET to tell them, look, we don't have really great data one way or the other. This is a new technology. If something comes up that's outside of this, localized area that is maybe a solitary lesion, then we're going to have a conversation about what next to do because we don't clearly know what else to do. From there, when I get that lesion, I usually do it in our multi-tumor board, our multi-D discussion, where we really review the imaging. Do we think it's real? Do we need a biopsy? Kind of what is the patient, really patient-focused, patient-centric discussions, and discuss with the patient what they want. And then, if everyone agrees, in a young, healthy patient, I would generally proceed with localized therapy.
I completely agree. If they were considering radiation, most times the radiation oncologist would want that node biopsied to determine whether they would increase the field.
So I guess this is an important information. So first, advise your patient about the potential result of the PSMA PET CT scan and that you might detect a solitary lesion or maybe an oligometastatic disease. And then you can still proceed with a local treatment in the multidisciplinary setting or multimodality approach of prostate cancer, including cytoreductive prostatectomy, radiation treatment, whatever. But it's very important to let the patient know that there is a probability to detect metastatic disease without impairing the oncological efficacy and the prognosis of him once you have discussed the treatment option. And I don't think that it is really justified to switch in these very, very specific cases just from local treatment to palliative treatment.
Okay. Thanks to Axel for inviting me back, as well as AUA to invite this course back. Good morning, everyone. I'm Jeff Carnes. These are my disclosures. And certainly what you're seeing is, this whole concept of molecular imaging has ushered in a new era when it comes to prostate cancer management. So some of the disclaimers, I will not talk about the different types of PSMA scans, nor go into the whole PET, CT, PET, MRI. And just to remind everyone, the metastatic status and treatments that have shown survival benefits have been determined by CT and bone scans or conventional imaging. So really a new era with all the PSMA data. We do not have long-term survival outcomes, but those are ongoing. What we have seen with PET is certainly we're going to see a stage migration. So we're going to be picking up nodes, bone mets, a lot earlier than we did with conventional imaging. So it's going to look like that patients are surviving longer, where in fact we're picking up the metastasis a lot sooner. And prior to any of this molecular imaging, you can see the distribution of metastatic sites in patients with recurrent prostate cancer was the bone, because we did bone scans as the PSA were rising. So this is certainly a bias compared to what we're finding now, and a lot of atypical metastatic sites that were previously undiscovered. So we'll focus on just a quick definition of biochemical recurrence, the performance characteristics of PSMA at biochemical recurrence, which is actually still evolving, and some of the implications regarding this PET and evaluation of recurrence. So we know that actually recurrent prostate cancer is a challenging scenario and a leading diagnosis that we all face, and that at least a third of our men who have undergone definitive treatment, i.e. prostatectomy, will actually be found to have a biochemical recurrence. And certainly distinguishing a localized versus systemic recurrence is an important step, including perhaps now identifying a oligometastatic relapse or an oligorecurrent relapse. Obviously, you've heard conventional imaging modalities are unlikely to be useful when PSAs are less than 5 or PSA doubling times are greater than 10 months, and the overall sensitivity is quite poor for conventional imaging. So Dr. K went over this. I won't go over it. The prostate salvage therapy guidelines were just reported at this meeting a couple days ago. I just will reiterate that PSMA PET is now completely acceptable according to guidelines in lieu of our conventional imaging or after negative conventional imaging. And there is a fairly strong statement that PET should be performed prior to salvage radiation therapy, which is now the gold standard in terms of postoperative radiation therapy compared to adjuvant therapy. So we have some time here. Certainly a negative PET, though, should not necessarily withhold salvage radiation therapy, because there is some data that if we're going to do early salvage, that we need to institute salvage therapy prior to a PSA or at a PSA of 0.5. So what is the optimal BCR definition? Certainly we use as a discipline 0.2 and confirmatory 0.2. Also 0.4 is actually completely acceptable. And perhaps sort of the sweet spot when we start getting PET scans for evaluation of biochemical recurrence. As you've seen, the performance accuracy of a PSMA PET scan is highly dependent on the PSA level, especially when it comes to patients with biochemical recurrence, because we have hopefully a pure PSA after the prostate's been removed. One thing that I tell our residents and fellows, if you remember one thing, just remember at a PSA of 0.5, you detect something on the PET scan about 50% of the time. So a take home 0.5, 50%. So as I mentioned, you can see here the distribution of metastatic sites that's reflective or dependent on the PSA level. So as you get higher PSAs, we're finding multiple regions. We're obviously finding disease in bones much earlier than we had with traditional bone scans. When do we get a PSA? When do we get a PET scan? Obviously, the guidelines suggest that a 0.2 PSA and greater, but I won't go into this nomogram. If you use nomograms, there are a number of them. This is one of the earliest ones, and you can see it takes into account the usual prognostic factors, and that's Gleason grade, the PSA doubling time, the time to biochemical recurrence, and then this uses a clinical stage. You can see the likelihood. They suggest that perhaps don't get a PET scan unless your probability is 20% or greater, just to potentially cut down on negative PET scans. This is one of the earliest studies that actually compared a PSMA PET to actually fluticasone or Emission. This is a prospective single center study. Patients were their own controls. So they got a PSMA scan, and they also got a fluticasone scan for evaluation of biochemical recurrence. So they had 50 patients who they enrolled into the study with a median follow-up of 8 months. So not a lot of follow-up. They're just looking at the initial detection rate. And it was powered to detect a little bit over a 20% detection rate differences. You can see that the detection rates with fluticasone were 26% and over 50% with a PSMA scan. Very strong odds ratio of almost 5. And the differences were observed in sub-analysis, mainly in the pelvic node region, of 8% with fluticasone versus 30%, and in the sub-analysis of extrapelvic lesions. You can see here the Acumen has 0% detection rate. So the take-home of this was that actually this is one of the earliest studies that supplanted other PET imaging, whether it's choline imaging, which I had a large experience in choline, or fluticasone in the evaluation of biochemical recurrence. And I certainly think that a PSMA PET is now the gold standard for evaluation, and it's fairly ubiquitous right now in the U.S. I will mention that, just as both my colleagues have mentioned, that it's not perfect. These lesions that were detected, even though there was a higher detection rate, were not biopsy-proven metastatic sites. So this is an interesting study also for patients who had biochemical recurrence, again, only after radical prostatectomy, where they looked at the salvage the clinical target volumes regarding salvage radiation to determine how much we would have missed with the PET scan. And you can see here, inclusion typical 0.2, 6 weeks after RP or later, and they confirmed a prostate bed recurrence described on PSMA, median time from RP to the PET. So these were fairly favorable disease here, 77 months, so over 5 years. You can see here, I won't go into all this data, other than to see that when you looked at the PSMA compared to the salvage RT volumes or dosimetry, you can see that they completely covered it in a little bit over 50% of the time, and about 30% were partially covered, and about 10% were not covered at all. So this explains some of the salvage radiation data, right? Which again, if you look at 10 years, only has durable PSA control of about 60% of patients, because a lot of times the salvage, they were radiating blindly, and sometimes perhaps missing the disease. This is an example of the potential, I think I went back, let's see. Example here, you can see that the green line represents the contouring of the salvage radiation, and you can see they would have missed some disease outside. So just to show you the potential value of doing PET imaging prior to salvage radiation, which obviously now is reflected in some of our disciplines guidelines. So this was also a study that looked at the predictive value of PSMA in men with biochemical recurrence undergoing salvage radiation. You can see here, this was a study from Australia, which has been ahead of the curve when it comes to utilizing PSMA PET scans in the monitoring and actually initial evaluation of their patients. You can see the inclusion criteria, median follow-up. And you can see here the sites of recurrence that were found on PET scan, including negative scans, fossa, pelvic nodes, distant nodes, and bone metastasis, and visceral metastasis, which obviously we did not see a lot of visceral metastasis when we used conventional CT and obviously bone scans. And here, as you've heard actually quite a few times, the PET results are reflected by the PSA values here. You can see here when you have a value of less than 0.2, 0.2 to 0.5, again, that sort of 0.5, 50% is right on target in most studies. And you can see here how the RT was administered based on the treatment, as well as the negative, the fossa positive, and the pelvic nodal disease versus distant disease that was seen on PET. And you can see here, this is actually a progression-free survival out to 3 years if they had a negative PET. Again, probably hitting the target most of the time, but not always. And here is a hazard ratio if they had obviously a PSMA negative or fossa scan versus outside the fossa. Again, underlying the value of perhaps getting a PET scan prior to initiation of salvage radiation therapy. And here you can just see this survival curve and freedom from progression. Again, if they had a negative PSMA scan or showing fossa disease only versus outside the fossa. So again, kind of going to that question, do we just do salvage RT or do we get PET imaging first? This is a historic study. You can see the historic cohort with the PSMA cohort, and if they got a PSMA, they were more likely to have a response to the salvage radiation therapy. You can see here, over a third in the PET group, the radiation oncologists changed their dosimetry based on the results of the PET scan, which I think is truly valuable and hopefully translates into better survival outcomes for our patients with biochemical recurrence. You can just see here, again, conventional imaging versus PET imaging. This is actually a fluciclovine study out of Emory that looked at the value of doing a PET scan prior to radiation. Okay, so this was actually a diagnostic performance, and again, early biochemical recurrence. Mainly these were patients that were treated with radical prostatectomy, so very relevant to this particular presentation. And you can see here the results for the PET scan in terms of the distribution of sites that were found on the PSMA PET scan. And again, PSA at PET and reflecting in the value of doing the PET scan appropriately. That sort of sweet spot, I think, is 0.5 or less when you're going to have at least 50% detection rate. And here, as you've also heard, Gleason score is also an independent feature related to the potential for a postoperative PSMA PET positive scan. And I put this in here because you can see here, you know, hopefully rightly, but over 50% of the time in this particular series, the management of the recurrent disease changed based on the PET scan. So we've seen disease management change in the initial staging as well as the recurrent staging. And I think that's also reflective now in our salvage prostate cancer guidelines from the AUA, SUO, and ASTRO. I mentioned this, it's shepherding this oligorecurrent state. So men have had a radical prostatectomy, develop biochemical recurrence, get a PET scan, and are found to have recurrent disease and potentially oligometastatic disease, which has various definitions, whether you want to use 3 lesions, 5 lesions, it's rapidly evolving. But what we do know now, sort of from bench to bedside basic science work, is that prostate cancer metastasis can independently metastasize. So there is some biological rationale for us to intervene on metastatic prostate cancers to perhaps change the course of their disease. So I will bring this concept up of a salvage lymphadenectomy. It is mentioned in our salvage therapy guidelines. It has been in the EAU guidelines for a number of years. And I found this case report in the Journal of Urology years ago, which was probably the first salvage node dissection of a man who had a rising PSA, was subsequently found to have a colorectal cancer, and during the low anterior resection in the pericollic lymph nodes, there was a prostate cancer node rather than a colorectal cancer, and this man's PSA went to undetectable levels. So again, this was over 20 years ago. So this was my series of men who underwent a prostatectomy, had BCR, after evaluation of a C11 choline scan. You can see the years here, and about 50% had a normal conventional imaging. And so of these 117, my intention was a bilateral extended salvage pelvic node dissection. It did include 15 retroperitoneal lymph node dissections, either done exclusively or in combination. And these are the 5-year Kaplan-Meier survival curves. Again, we're not curing a lot, but we wouldn't be curing these patients if we were giving them a systemic therapy either, and perhaps delaying their time to ADT. These patients were not treated with ADT afterwards. You can see here the 50%, this is a progression-free survival. They were not found to have recurrent disease on PET scan, even if their PSA rose. And so what were the 2 main factors that actually predicted a better recurrence freedom? And that was actually the original biology, whether it was a T2 versus a T3 or greater, whether it was a high Gleason score versus low Gleason score. So it's not necessarily our imaging, it's not necessarily our surgery, hopefully, but it's the biology of the disease that predicts recurrence. This is a lot of times perhaps short-lived, because if you follow these patients out past 5 years, you can actually see that they continue to have PSA recurrences, but perhaps raising the question of whether we can salvage them with other forms of metastasis-directed therapy, whether it's radiation, even potentially cryo, surgery, and so forth. So this is a study because that I contributed with the Heidelberg group, Martini Clinic, where we looked at patients who had BCR after radical prostatectomy and postoperative radiation therapy, so maximize treatment locally and compared them to a patient group that had no intervention in terms of metastasis-directed therapy. You can see here there's over 263 patients. Salvage nodes were 166. Pelvic nodal SBRT or radiation therapy, 97. We actually matched them as best we could and looked at the impact of metastasis-directed therapy on their survival. And you can see here, if we intervened versus no metastasis-directed therapy, the patients we intervened on, whether by surgery or by salvage radiation therapy to nodes, they tended to do better. You can see here, again, propensity score matched and even further curve separation. So again, not high-level data, but hopefully good retrospective data to show that metastasis-directed therapy, or MDT, may improve the survival for nodal recurrent prostate cancer after maximized therapy to the local disease after radical prostatectomy and postoperative radiation therapy. So let's move into radiation therapy as a form of metastasis-directed therapy. When we do find oligometastatic disease, there are some ongoing studies. These are all in the hormone-sensitive oligometastatic prostate cancer. There is the Oriole, the STOMP, and the ongoing SABRE-COMET. SABRE-COMET is an intervention only by SBRT and is not prostate cancer specific, but prostate cancer made up about, I think, about a third of that entire patient cohort. And we won't go into that because that tended to use actually conventional imaging to find metastasis compared to the Oriole and STOMP. So this is the STOMP study that was led by Piet Oost in Belgium, and they randomized patients based on choline PET scan. So this is not a PSMA scan, but a choline PET scan given the era. They had to have 3 or less oligometastatic sites, and then they were randomized to either radiation or surgery versus just monitoring. If they had polymetastatic disease, then it went ADT. So you can see here that this is a waterfall curve regarding the PSA, and that even patients, again, low PSAs, even under surveillance, some of the PSAs jumped around. And that's one reason I tend to try to use even either confirmatory 0.2 or a PSA of 0.4. And you can see with the intervention, the metastasis-directed therapy, the majority of patients did undergo a PSA decline. And here is just the biochemical recurrence survival. But I think the key here is actually avoidance of palliative ADT. We know that our patients don't like it. It has really no good survival outcomes when it comes to getting it early versus waiting for more symptomatic progression or polymetastatic disease. You can hear the ADT freedom was actually doubled essentially at a median of 3 years. This is the Oriole study, which it's not a pure PET study, but they intervened on bone lesions. And you'll see that actually the median progression-free survival was not reached in this particular study if they had intervention to the bone lesions compared to just purely observation. And this was just follow-up study of combination of the STOMP and Oriole studies that I just showed you, the STOMP from Belgium, the Oriole that was led out of Hopkins. And here it just showed a benefit, but also a benefit in patients who had high-risk mutations. So homologous recombinant deficient mutations and so forth. So again, I didn't want to spend a lot of time on metastasis-directed therapy, just show you some of the implications that we find clinically with using PET scans and what to do with it. Ongoing studies, but again, salvage radiation, salvage surgery can be acceptable for patients with oligometastatic disease. So I have some cases, Axel, if you want me to run through them. I don't have the audience response system, but these are some actual cases that were in my clinic. Sorry, I'm just having a little trouble with it. Okay, so this is a patient I operated on well over 10 years ago. And he, at surgery, he had a T3B, 0 to 27 nodes, negative margin, and his first PSA post-op was 0.4. And here, this is an MRI, and this is actually a choline PET scan. You can see here an oligometastatic recurrence only in the iliac bone. So one question that I would have is, how would we treat this? So traditionally, patients would have been treated just on systemic therapy, but now we have a single oligometastatic bone lesion. And as a radiation therapist, I don't think we probably have any in the audience, but would you actually treat the fossa because of T3B despite negative imaging and negative margins? So anybody want to speak up, or I'll just tell you what happened. Go ahead, Axel.
So what I would do in this situation, reflecting also a couple of phase 2 trials, I would do a stereotactic radiation to the bone lesion and add ADT for 6 months. This at least gives a good long-term response of treatment. You don't have to add long-term ADT, but that would be my choice in this situation.
So actually, he just underwent a single fraction of SBRT to that bone lesion and without ADT. And then he stayed undetectable for 4 years. And actually now he has some oligometastatic recurrences in his lung parenchyma that our radiation oncologist is sort of picking them off as they show up. Another case, 78-year-old, T2, 3+4, 0 to 12 nodes, all negative. This was in 2016. Recently saw him about a year ago, and you can see here his PSA is 0.75. If you look closely at this MRI, you'll see actually a little node here that obviously by conventional imaging, radiology report, this would have been read as a negative scan. And then here's the PET scan showing an isolated pelvic node. And this was actually radiated. So kind of a similar type of thing here where patient Gleason 7, PSA 1 year later 0.2, then 0.3, negative MRI. With the negative MRI, still underwent salvage radiation without ADT, fossa only. Nadir PSA went to 0.2 only. Subsequently, PSA started rising, PSA 0.75. You could see the PSMA PET scan. Node here, and actually manubrial lesion, and then a first rib lesion here. So this patient was treated with basically radiation to the pelvis and SBRT to these 2 nodes. Ongoing PSA monitoring. So sort of to conclude my talk, certainly PET scanning has changed how we actually tend to prostate cancer now, especially in biochemical recurrence. And I think out of all the disease states we see, I think the most relevant place for a PSMA is in the evaluation of biochemical recurrent disease. And obviously PSMA is the imaging agent of choice. There certainly is a rationale to augment our salvage radiation and how we refer to radiation oncologists with the introduction of PSMA PET scan. It's fueled the growth of oligometastatic disease or oligorecurrent disease, and certainly there are unique opportunities for us and our patients with continued investigation in survival benefits of intervening on oligorecurrent disease. So thanks, open for any questions.
Okay, so if there are no questions, then I will just continue with the last part of the presentations, which will be radiorecurrent disease. So the role of PSMA PET scan in radiorecurrent disease for patients who have received radiation treatment to the prostate and who recur. The problem of all these patients is, let's see if I can. So the problem of all these patients is still, even nowadays, this is a study from 2014, but even today, most of the patients who relapse after radiation treatment locally receive androgen deprivation therapy. So we give systemic treatment, although there is only a local relapse, which could be treated locally with a secondary option, which will result in a high cure rate. So in my view, radical salvage prostatectomy is one of the most significant curative procedures, second-line curative procedures in those patients. And we have to think about this type of treatment much more often than we did in the past. But we have to use modern innovative imaging studies to rule out those patients who will not benefit from this local approach. So either the ones who have occult pelvic lymph node disease or the ones who have occult systemic disease who definitely will not benefit from this type of surgical approach. The purpose of any type of this secondary local approaches are very easy. There is either to improve the long-term cancer-specific survival. You want to maintain the functional integrity of the patient, especially continence. Potency is very difficult to be achieved, and there should be a low frequency of surgery-associated complications. You want to prevent local complications due to the local progression of the disease if patients only undergo androgen deprivation therapy. And all of you know the patients who have this local progressive disease, subvesical obstruction, gross hematuria, blood clots, upper urinary tract obstruction, so very difficult. So I just want to go a little bit more into detail. How do I select patients who might be candidates for radical salvage prostatectomies? And right now we have done more than 400 of those cases, so we're probably quite experienced in this setting. So this is what I do in my patients. So usually I get a PSMA PET scan to rule out locoregional and systemic metastases. And we also use the multiparametric MRI and the PSMA PET scan to rule out extraprostatic extension. The other thing is patients have to have a long life expectancy so that they will benefit from this type of surgical approach, and the patient at least have the willingness to accept that there is an increased local morbidity in terms of incontinence, in terms of impotence. However, patients will have good long-term outcomes with a long overall survival and with a good biochemical relapse-free survival of at least 75% if you select patients carefully. And careful patient selection means that you use innovative imaging studies. We have looked at some patients why they should not be treated by radical salvage prostatectomy, and especially patients who have positive lymph nodes at time of salvage prostatectomies are the ones who only have a short period of time in which they will benefit. This is just the analysis of our patients. So if you don't have a positive lymph node, your mean biochemical relapse-free survival is more than 5 years. In patients who have been diagnosed with organ-confined disease, it's more than 8 years. If they have positive lymph nodes, it comes down to 1.5 years. So what we did in this situation, we had a series of patients in whom we used the multiparametric MRI and in whom we used the PSMA PET scan to identify either extraprostatic extension or positive pelvic lymph nodes. So 113 patients had undergone multiparametric MRI, and 53 out of those patients had undergone a PSMA PET scan in this situation. All of the patients received typical biopsy procedures, and the mean age was 61 years. The median PSA prior to radical salvage prostatectomy was 5. And as you can see, the majority of patients, 80% of those patients, did have organ-confined disease. This is double, I don't know. This is a typical image of those patients, a typical multiparametric MRI demonstrating a small focus or even a large focus of radiorecurrent disease in those patients. When we did a PSMA PET scan in the same patient, we could delineate the same intraprostatic localization of the tumor. We also identified the infiltration of the seminal vesicle, so those patients usually get a biopsy of the seminal vesicle and then they undergo surgery, which was then locally organ-confined disease, negative lymph nodes, and a negative surgical margin. When we look at the detection rates with regard, let me see if I can advance the mouse to there. When we look at the detection rates of the resected and recurrent prostate cancer, then PSMA PET scan is even superior to a multiparametric MRI to identify this locally recurrent disease. And also the PSMA PET scan is superior to the MRI to identify patients who have organ-confined or locally advanced disease. However, as in the situation of the initial primary staging in locally advanced disease, the PSMA PET scan still does poor in identification of pelvic lymph nodes. When we look at sensitivity and specificity of these multiparametric MRI and the PSMA PET CT scan, we see that in most of these scenarios, the PSMA PET CT scan is superior to the multiparametric MRI in terms of the detection of locally advanced disease, but it is even not very good in the detection of pelvic lymph nodes. So you can use a PSMA PET scan to stage your patients at least locally and systemically in order to have an idea if this might be a candidate for some type of local curative treatment as a second-line treatment like radical salvage prostatectomy. However, as in the situation of the treatment-naive, locally advanced prostate cancer, you always have to do this type of extended pelvic lymphadenectomy to identify those patients who might have positive lymph nodes. So the conclusion, and this is one of the only studies which has concentrated on PSMA PET scan in radiorecurrent disease, we have a high accuracy of both methods to identify local recurrent disease. So we might even discuss to spare a biopsy in those patients prior to any type of local treatment, because we never had a false positive PSMA PET scan in this situation. There is a high accuracy of positive lymph nodes if the PSMA PET scan is positive, as you already have heard from Dr. K. And there is a low accuracy to predict these positive lymph nodes. So I don't know, this is something which I corrected, but which somehow didn't work. So this is basically all what I wanted to say. So use a PSMA PET scan in locally recurrent prostate cancer in order to do or to make your decision if this is a patient for radical salvage prostatectomy. And just looking at the cases we have done, I've just separated the cases and let's say the difficulties of the surgery dependent on the type of radiation therapy which was performed. If the patient only underwent EBRT by EMRT and EGRT, you will expect fibrosis in the radiopubic space, and you will expect fibrosis in the area of your pelvic lymph node dissection. If the patient has undergone any type of brachytherapy, you will expect a dense, I don't know what's this, you will expect a high fibrosis in the area of the apex and in the area of the rectum, which also differs then dependent on the type of radiation therapy. And I guess that's the bottom line message. And I have a video on radical salvage prostatectomy, but that's not the main issue of this talk and this presentation. So I guess we can skip this. The bottom line message is to use this type of PSMA PET scan in the scenario of locally recurrent disease. That's all with a small presentation on local recurrent disease. So we have a couple of minutes if you would like, and if I can move this mouse to the screen here again.
I have a question for you,
Yeah.
Axel. So, the Phoenix definition, which
Yep.
is nadir plus 2, obviously when the PSA gets to 2, the PET scans are usually going to be positive, usually,
Yep.
not always. But the Phoenix definition basically predicted maybe about a 50% chance of local recurrence rate. But even this is pre-PSMA, this is pre-MRI, but the rest of it, 50%, were actually systemic. So I think we really have to look at, especially with modern molecular imaging, reevaluating the definition of radiation recurrence. Because most of the times when we wait for a nadir plus 2, it's going to be actually not necessarily curative.
Yeah. So what we do is we use somehow the Phoenix criteria. However, if I have a patient who has like a consecutive rise 4 or 5 times in a row, I know this will be locally recurrent disease, and I don't wait for the
Right.
0.2 definition. I just do my imaging studies earlier and I start treatment earlier. The only thing where I'm quite suspicious that this PSI rise might not be due to locally recurrent disease, when you have like 2 or 3 rises about a year or 18 months after radiation therapy, it could be a PSA flare-up or bounce phenomenon. So I just do another analysis like 6 to 8 weeks afterwards, and then usually PSA decreases if you have the bounce phenomenon. If it does not decrease, I start with the imaging studies, but I don't wait until this such long time
Yeah,
as the Phoenix definition would tell us.
I wasn't presuming that at all, but in the
Yeah.
U.S., we
Yeah,
mostly don't see these patients
Mhm. Okay.
because they're monitored by radiation oncologist.
Okay.
Yeah, so I think there's a referral issue sometimes if they wait
It's
to the.
interesting, yeah, because in Germany the situation is so the patient has undergone radiation treatment,
Uh-huh.
then he has his follow-up examination with the radiation oncologist, but only to assess the patient for treatment-associated toxicities. For the PSA evaluation, the patient is referred to the urologist.
Wow.
So we always see those patients with a rising PSA, and then we can just intervene in terms of all early diagnoses and treatments. Mhm, mhm.
But
Okay.
in the U.S., it's just the opposite. They usually see the urologist for all the toxicity and get their PSAs from the radiation oncologist.
Okay. Good. So I don't know if how long do we have time? 5 minutes. Okay. So I guess we can at least do 1 or 2 cases because we have otherwise we have to head to the airport. Sure.
It's kind of an expert opinion. So when you get a PET scan, a PSMA PET scan, and you might see a single lymph node, and the patient is adamant they don't want SBRT, they really, they have that mentality, I want it out. Surgically, would you just go after the node? Would you talk them into a more extended lymph
Yeah.
node dissection? How many nodes would it take before you
Mhm.
did the full extended lymph node dissection?
So
So
is this
what-
recurrent disease or?
Yes.
Yeah.
Mhm. No. So one thing is you have to identify, let's say, the best candidate for this type of salvage lymphadenectomy. And we have done a multi-institutional trial where we developed a nomogram, which you can download from the internet and calculate the risk of biochemical relapse 12 months after salvage lymphadenectomy. And you identify patients who have PSA doubling time more than 1 year, patients who have only 2 visible pelvic lymph nodes in the small pelvis, patients who have a time interval between radical prostatectomy and visibility of this lymph node more than 1 year, have the highest chance to be at least benefit long term from this type of salvage lymphadenectomy. When we do a salvage lymphadenectomy, we at least do a unilateral extended template because we find additional positive lymph nodes in about 30% of the patients. And only if the patient would have some type of this, let's say, more aggressive biologic characteristics, ISUP4, ISUP5, a rapid PSA doubling time, then we would do a bilateral pelvic lymphadenectomy, because then you also have a higher probability that you have micrometastatic disease on the contralateral side. So the bottom line is whenever a patient decides that he wants to have this lymph node out, he at least needs to undergo an extended pelvic lymph node dissection on the ipsilateral side. Okay, maybe we can just discuss this one. We can discuss this one patient. This one doesn't move. Pardon me? So now we have it up here. Okay. So this is a patient who had undergone a radical prostatectomy for, let's say, locally advanced disease. His PSA postoperatively turned down to non-detectable levels. He had a PSA rise to 0.17 2 years postoperatively, and then he underwent early salvage radiation therapy with 71 gray to the prostatic fossa. His PSA came down 3 months after radiation treatment, and thereafter it rose slowly. He had then a PSA of 1.3 within the following 2 years. His PSA doubling time at that time was 18 months. So the question is, first, would you perform a PSMA PET CT scan in this situation? I guess everybody would do it, as we have discussed it by the previous discussions. The question is, what would you expect in this situation? So you have heard from Jeff and also from Dr. K, you should only do a PSMA PET scan if this will influence your treatment. So if you would expect, for example, skeletal or visceral metastases, most probably you could do a conventional imaging or start patients immediately on androgen deprivation therapy. If you would expect local recurrence and your patient might be a candidate for some type of local treatment, then definitely a PSMA PET scan would be advisable. And the next question is, which tracer would you use in this situation? And the selection of your tracer depends on what you would expect with a PSMA PET scan. So for local recurrence, as we discussed, you would use the 18 fluoride 1007 because it's not excreted renally. If you would expect a systemic disease, bone disease, you might use the gallium tracer, and you might repeat your PSMA PET scan if it's negative with this F18 1007 tracer. So in this situation, yes, you should perform a PSMA PET scan, and I don't know. You would expect local recurrence and maybe locoregional lymph nodes. And in terms of the tracer, in this situation, I definitely would use the fluoride 1017 tracer. What we detected in this situation is then a patient who had this type of relapse. What we were thinking, so you have the bladder here. You see all the clips here nicely after robotic-assisted radical prostatectomy. And then you have this type of locally recurrent disease. What could that be? Our nuclear medicine people are usually nice. They call it's a PSMA lesion in the dorsolateral area of the bladder because they don't want to blame the surgeon. It's a seminal vesicle remnant, which never should be there. Because if you do a proper radical prostatectomy in this type of patients, you need to resect the seminal vesicles completely. Don't leave behind the tip of the seminal vesicle for whatever reason. And if you use the PSMA PET scan, we can see these seminal vesicle relapses in about 8% of all patients. And we also see positive lymph nodes in the area of the internal, external artery and the obturator fossa. So taking into consideration these locoregional relapses, about 43% of all these relapses could have been avoided if you would have done a proper anatomically correct surgery. Extended pelvic lymphadenectomy, taking out the seminal vesicles. But coming back to this case, what would you do in this situation? So he had undergone radical prostatectomy. He has this seminal vesicle remnant. So what would you do? Would you do androgen deprivation therapy? Would you ask your radiation oncologist to place some seeds in the seminal vesicle? Would you do a salvage resection of the seminal vesicle or just active monitoring until there is progression, symptomatic progression, whatever? I don't have a polling question, but what would be your choice, or what would you do, Jeff, in this situation?
Oh, I think you probably know what I would do. I think you probably know what I would do.
Sure.
But I would consider it for seminal vesiculectomy given his young age.
Yep.
And the other thing to think about for these is percutaneous ablation, depending on the closeness of the ureter. But I have referred for some percutaneous cryo or something.
And Deborah, what would you do at Duke?
Yeah, I agree. He has a long PSA doubling time to begin with. He's young. I would have a conversation with him that we can do surgery. It may be associated with higher risks. But with radiation, I'm really concerned about toxicity to the bladder and the bladder neck and secondary malignancies given his young age. Yep. The other option, just giving the long doubling time, if you really didn't want to undergo the morbidity of surgery, is just to observe it and follow his doubling time.
Okay. In this situation, we did the salvage resection of the seminal vesicles. When you do it, it's always difficult. We do it with a transperitoneal open approach, and you can see this dense fibrosis in the dorsolateral area of the bladder, so it is very difficult to identify the exact plane between the seminal vesicle, the dorsal wall of the bladder, and the anterior wall of the rectum. So what we usually do is, in this situation, we identify the spermatic cord or the vas deferens at first, and then we use the vas deferens as the anatomical landmark to guide us to the seminal vesicle. And once you have identified the seminal vesicle in this dorsal space, just in the area between the rectum and the bladder, then you can nicely dissect out the seminal vesicle. Sometimes it's a seminal vesicle like this, so never has been touched during the surgery. Sometimes it's just the tip of the seminal vesicle, but this is how we would manage cases in this situation. But the bottom line is do a proper surgery to avoid this type of treatments and to avoid potential complications associated with salvage treatment. So if you don't have any other questions, I guess all the three of us, thank you for attending this instructional course on the use of PSMA PET scan, either for initial diagnosis or for diagnosis of patients who have some type of relapse following a local treatment, be it radiation therapy or radical prostatectomy. And I wish you a nice Sunday, a nice ongoing AUA, and maybe we see us back in 2025. Thank you very much.